chronic cough. So let's talk about chronic cough in the pediatric patient.
All right.
So what's the definition of a chronic cough?
Lasting more than 8 weeks.
Fantastic. So a cough more than 8 weeks. Sometimes they'll even say more than 4 weeks. So you have a patient presenting to you who has a cough more than 8 weeks. What questions do you ask?
When did this start?
Okay, fantastic.
What type of cough? Is it wet or dry?
Beautiful. So is it a dry cough or is it productive? If it is productive, what does that look like? What else?
How
has
often?
it changed?
How often?
yeah.
How has it progressed?
Okay, fantastic. So how often, so what do you mean by how often?
Like, is it occurring once a day, twice a day, worse in the morning or at night?
Fantastic.
Something
So
like
that's definitely one of the key things, especially in pediatrics. Is it worse at night? Is it worse in the morning? Or is it happening throughout the day? And how has it changed? That's excellent too. So is it a cough that came and went away or seemed like it was going away and then it's come back again? That would make you think more of what?
Cough that's
That came back.
So a cough that started 2 months ago and got pretty bad, and then it seemed like it was getting better, and then it got pretty bad again.
I would still suspect asthma potentially.
Or any allergies?
Or
Okay, or URIs. When we hear that type of situation, we think of back-to-back URIs. Yeah, viral URIs, one of the most common things that you'll see in pediatrics. As opposed to this chronic cough, like the patient that we saw today, had 2 months of this chronic cough, worse at night, dry, and seemed like it was getting worse the whole time. Mom said it never got better. So that makes us more suspicious of other things. What other questions do we want to ask about chronic cough?
Any fevers associated?
Fantastic. So any fevers and when they were. So did they just have fevers in the beginning like our patient and then no fevers since then? Or have they suddenly spiked a fever? Because that's certainly going to change our differential. What else?
Any problems breathing?
Okay, fantastic. Difficulty breathing, shortness of breath. Is it harder for them to exercise? Beautiful.
along with that, like skin changes too. Like, are they getting pale or cyanotic?
Absolutely. So pallor, cyanosis, and then any other constitutional symptoms, right? Night sweats, weight loss, all of those type of things. Do they seem more fatigued and tired? And then if you're thinking about different infectious etiologies, what are some questions you want to ask about that?
Anybody sick around the house?
Fantastic.
Anybody exposed to
So
TB?
sick contacts,
Any travel?
tuberculosis contacts, beautiful. Any recent travel? And there's one more that I was thinking of.
Camping or
Okay, so camping,
outdoors?
sure, that kind of goes in with travel, but absolutely. And then specific to the pediatric population.
Like whooping cough, like pertussis. So how vaccinated? Are they?
Fantastic. So what's their immunization status? Beautiful. I love it. Okay, so now let's talk about our differential. So let's talk about a patient who has had a chronic cough. Let's talk about our patient. Chronic cough, it's been dry and really only at night. A nocturnal dry chronic cough. What's on our differential for that?
allergies?
So allergies, seasonal allergies, fantastic. Allergic rhinitis would be the diagnosis. Why is it worse at night?
Because you're laying down.
Yeah, absolutely. They have that post-nasal drip when they're laying down. So laying down, they have that post-nasal drip, so it'll be worse. Oftentimes that cough, it can be dry, but oftentimes that's a wet cough because you're coughing up all of that post-nasal drip. But allergic rhinitis for sure. What on physical exam would make you suspicious, more suspicious of allergic rhinitis?
Runny nose.
Okay, so runny nose, sure. What else?
Erythema in the nasal septum.
Yeah,
as well
or
as the tonsillitis.
aside from erythema, when you're looking at the turbinates, if they're pale and boggy and inflamed. So instead of being flat and pink like the inside of our mouth, you look inside their nose and they're really, really swollen and they're pale, almost a bluish white. That would make you think about allergic rhinitis. And then we think they'd have other symptoms of that too, right? Watery eyes, sneezing, runny nose, as you mentioned, maybe some cobblestoning, evidence of cobblestoning in the very posterior oral pharynx. Fantastic. So it's not allergic rhinitis. This patient had perfectly normal turbinates. So what else is on our differential? Dry cough, worse at night.
URI. Start thinking viral.
So viral URI, sure. How long should the typical URI last?
3 weeks.
Oh,
Not kidding.
goodness, you guys have bad URIs. 7 to 10 days, right? That's what we tell the patients. It's typical URI lasts 7 to 10 days. He may have started with a URI because he did have fever in the beginning. He did have some nasal congestion and stuff in the beginning, and that all got better. So it may have started with a URI. And like I said, if those symptoms get better and then get worse again, we think, oh, it's just back-to-back URIs. Kids can have up to 10 URIs a year and still be considered completely normal. So that may have been what happened, although that doesn't sound like the case with this. If he still had those URI symptoms for longer than 10 days, I'm going to be concerned. So probably not URI. What else? Dry cough.
Suspect asthma.
Asthma, totally. So that is like the highest on my list. He's right in the right age range to get that new diagnosis of asthma. He doesn't have a family history of atopy. And when I say atopy, which 3 disorders do I mean?
Right.
Eczema.
Atopic dermatitis is the medical term for eczema. So atopic dermatitis, asthma,
Seasonal allergies.
yeah, exactly, and allergic rhinitis. So he didn't have any family history or personal history of atopy, but he's the right age range for it. He has this dry cough that's only really happening at night, and it's been going on for 2 weeks. So that's top of my list. Look inside his nose. He doesn't have any evidence of allergic rhinitis. He doesn't have any other symptoms of allergic rhinitis. What do we do? How do I diagnose asthma in a patient like this? So I could send him to a pulmonologist, right, and test his pulmonary function test.
Yes.
I could test his peak flow. What's the key thing? What's the key thing about any of those tests for asthma? If you find something, it has to be reversible, right, with a beta agonist, so with albuterol.
Yes.
So you find something, you give them albuterol, and it gets better. So what we usually do in the outpatient setting is if it's a mild case like this, I prescribe albuterol and I have mom try it at home. So here in the office, he's totally asymptomatic. He's not wheezing. It sounds like his symptoms aren't acting up until nighttime, which is typical of asthma. And so we send them home with albuterol. I instruct them how to use it with a mask and a spacer. And if it gets better, then at least he has reactive airways, and we know his airways are reacting positively to the beta agonist. But most likely, he probably has asthma. So we'll just wait and see if it happens again. And then we can start talking about the classification. Fantastic. So asthma's highest on my differential. So now let's say this time that he has had more of that URI, but it's been going on for the last 6 weeks, which just sounds like so long. But he's got lots of congestion. He's got more of a wet cough. Maybe he had fever initially and the fever went away, and now the fever has come back again. Now, strep throat doesn't have a cough, right? So if you hear a patient has a sore throat and a cough, you think viral,
like
you
a
don't think
sinus.
strep throat.
Sinus
Infection, totally. So sinus infection. So especially those URIs that last really longer than 2 weeks. So it's lasting longer than 2 weeks, especially with a new onset fever. May have started out as a URI. Their sinuses may have gotten inflamed and kind of become this nidus for infection. So bacteria get in there and they're unable to get rid of it. So yeah, really anytime a child has that persistent cough that is wet and productive, maybe worse at night as well because of that postnasal drip factor, and they have new onset fever, we think sinusitis. So a productive cough, worse at night, longer than 2 weeks. We're thinking sinusitis. What sinuses do kids have?
Frontal and maxillary? No.
Nope. They're,
Ethmoid.
yes, exactly.
Ethmoid.
So you're born with your ethmoid sinuses, so they definitely have ethmoid sinuses. They have some maxillary sinuses, but they're not very well developed. They really don't fully develop their frontal sinuses and maxillary sinuses, at least their frontal, until they're teenagers. So we don't think of them being all that significant. So in adults, you tap over the sinuses to see if there's any tenderness. In kids, you can't tap over the ethmoid sinuses, so that's not going to be a very effective test. So really, we just presume sinusitis if they have those symptoms, that productive cough for longer than 2 weeks, especially with new onset of fever. What bacteria are we worried about in sinusitis?
I'm bringing it back to like strep pneumo and like.
Okay, I love it.
Moraxella.
I love it.
All of
Strep
them
pneumo, Moraxella catarrhalis, and one more. These 3 are very common in another area of the Haemophilus influenza. Which type?
B.
Non-typeable.
Non-typeable.
Yeah,
Just
okay,
kidding.
trick question. Type B is the one that we have a vaccine for, so it'd be nice if it was type B, but it's non-typeable. But those 3 are the most common causes of ear infection and the most common causes of sinus infections. What do we treat pediatric sinusitis with?
Amoxicillin.
Amoxicillin, fantastic. High dose or regular dose? Regular dose amoxicillin, and you guys don't need to know dosages, but you do need to know the difference between high dose and regular dose. Regular dose amoxicillin is about 25 to 50 milligrams per kilogram per day. High dose is 80 to 90 milligrams per kilogram per day. So it's almost double, in some cases more than double. We would give high dose in this instance. Can you guys tell me why we might give high dose amoxicillin?
Because of the chronicity, as well as you don't want the spread of the infection to go into the brain.
Fantastic. So part of the reason why we treat it, right, because the body is self-healing. Even with bacterial infections, our body's going to heal itself. But we certainly want to prevent any dangerous sequelae like meningitis, like that direct extension of the spread. We're doing a high dose amoxicillin partly because of the bacteria and partly because of the location. It's hard to get into the sinuses. So in order to penetrate into the sinuses, we really need those high blood levels of the drug. What is the virulence factor for strep pneumo? Strep pneumo's number one virulence factor.
Strep pneumo is the capsule.
Fantastic. It's encapsulated.
Yeah.
So it's encapsulated. What can strep pneumo have on its capsule that may prevent the ability of penicillins to be effective?
Beta-lactam.
The
Hold that thought for later.
polysaccharides.
It has, so that's part of the capsule.
Okay.
It has something that the abbreviation is PBPs, penicillin binding proteins. So they can have penicillin binding proteins on that capsule. If you have penicillin binding proteins, we give high dose because we want to overwhelm all of those penicillin binding proteins. So all the binding proteins get bound up with penicillin, and then we still have more that are able to come in and cleave that to penetrate the capsule. And then you mentioned beta-lactamase or beta-lactamase. What is beta-lactamase?
So it's
It's an enzyme that it deactivates the medications potentially.
Yeah, fantastic. So it cleaves that beta-lactam rings of penicillin, right?
Yeah.
And the penicillin we use is amoxicillin. So that's another virulence factor, potential virulence factor of strep pneumo. Strep pneumo can make beta-lactamase. If it does make beta-lactamase, what's that going to do to our amoxicillin?
so it'll kill. It's like the efficacy.
It's going to render
Yes.
it pretty much ineffective, right? So we're going to put this kid on high-dose amoxicillin, and they're not going to get any better. Or maybe they'll get better initially, and then they'll start to get worse.
Yeah.
And so then what medication would we give them?
Clavulanic acid.
With amoxicillin,
With
right? Because clavulanic acid is
A beta-lactamase inhibitor.
fantastic, a beta-lactamase inhibitor. Beautiful. So we would move to Augmentin. That's the brand name for amoxicillin plus clavulanic acid. And we would still dose the amoxicillin high dose. What if the patient's penicillin allergic?
You could switch to a different class and try like a cephalosporin.
Sure, so you could try a cephalosporin, right? There is some cross-reactivity, potential cross-reactivity of patients that are allergic to penicillin, that they may be allergic to cephalosporins, but that percentage is very low. So you can feel pretty safe doing that, especially telling parents what to watch for. What about another class?
Ciproflox. No.
So ciprofloxacin is a fluoroquinolone. Why don't we give fluoroquinolones to kids?
It's Achilles rupture.
Fantastic,
Yeah.
tendon rupture, absolutely. So we try to avoid, there are some instances where we can't avoid it, but we try to avoid giving fluoroquinolones to kids. What about a macrolide? Can you name a macrolide for me? Azithromycin, totally. So azithromycin may not have the best penetration into the areas that we're wanting, but it's certainly an option for those patients that are penicillin allergic. One last thing about chronic cough before we cut it off. Can you think of something outside of the airway tract? One of you mentioned this actually when we were talking about our patient. So it may especially cause a cough that's worse at night. This patient may also complain of some chest pain or some belly pain.
Oh, like GERD. Or
GERD,
reflux.
absolutely, reflux. So certainly something that we want to think about with those patients that have a chronic cough is reflux. Could they be refluxing all the way up their system and then actually aspirating some of it? So then I'd be worried about aspiration pneumonia and things like that. But so you definitely want to get some history of GERD symptoms. Awesome, thank you.
Awesome.